alkali forms mostly as a bicarbonate. One important factor is the CO2 transfer across the biological membranes is 20 times more efficient than the oxygen transfer in any biological membrane. That's an important concept, and we'll again mention this later on. So oxygen carrying capacity, if you think about that, it is three things are important: hemoglobin concentration and a saturation, and a very little amount in the dissolved plasma O2 there. So if you talk about the what most influences oxygen carrying capacity is actually hemoglobin concentration there. So again, if you have to improve oxygen concentration, oxygen content of the blood, you have to improve the hemoglobin there. Though the saturation is usually kept between in the 90s. Once you are in the 90s saturation, the improvement in the saturation actually doesn't improve the oxygen content that much. So what hemoglobin you have to use in ECMO? Normally in the neonates we target about 13 to 15 grams, and children 12 to 14 grams per deciliter. Now, if you look at your current critical care world, if you're not on ECMO, you don't transmit to this level. Okay, so if your hemodynamic is stable in our unit, I don't transfuse until hemoglobin reaches to 7. Okay, in a critical hemodynamic instability, I would transmit probably to 10. But in ECMO, if you have to use that, you have to increase your flow to such a high extent, okay, to deliver the same amount of the oxygen. So to decrease the ECMO flow, we actually have to increase the hemoglobin concentration there. So again, if you're on ECMO, trying to keep higher hemoglobin concentration is very important. Let's talk a little bit about the delivery of oxygen and then oxygen consumption. If you go through this curve, as we decrease the oxygen delivery, the total amount of oxygen delivered is decreased, the VO2 remains constant up to some extent. This is done by extracting more oxygen to the blood which is going through this. Okay? At the end, what happens is the blood coming out of the tissues will have a low oxygen content, that means low saturation. So your venous saturation is going to be lower when you have a delivery is less and then your consumption is constant. At a certain point, your consumption goes. So again, just a fixed principle, everybody and most of your cardiologists, you know the relationship there. Most important thing is your VO2 depends upon the gradient or difference between the arteriovenous saturation difference. That's what it is. So whenever the either delivery is decreased or consumption is increased with a fixed delivery, your venous saturation goes down. I want you to really remember this part of it is. So central venous saturation reflects the balance between the delivered oxygen versus consumed oxygen there. So SpO2 is decreased with either decrease in cardiac output and increase in VO2. Why is this important is central venous saturation is the most important parameter monitoring adequacy of your cardiac or oxygen delivery during VA ECMO. If you have to monitor only one thing you want to monitor a central venous saturation. I really do not know. Sometimes my nurses come over, your arterial saturation is falling there. I only ask what is your venous saturation. If venous saturation is 75, I would say don't worry about it as long as everything else is working out okay. So the arterial saturation is not that much important as long as venous saturation, because it tells the balance between your delivery versus your consumption. Now, so when your delivered oxygen becomes lower than this, what is called critical point, your VO2 comes down, then you becomes a tissue hypoxia, lactic acidosis, or organ failure there. So this is a portion what is called the VO2 depend on the DO2. Normally VO2 is not dependent upon your oxygen delivery. Now, a couple of the other things is when you put a patient on a full AV ECMO, VA ECMO, and what happens is there's no native cardiac flow, so there's no pulsatility there. So there was a big controversy in between is the pulsatility is important for organ function or not. What they've shown is if your pump flow, total flow is good enough, there's no problem with the pulsatility or not. If the flows are low, total cardiac output is low, pulsatile flow has some protection against organ ischemia. So we talk about the ECMO and lung function. In all forms of ECMO, CO2 removal is more efficient than oxygen addition. We have talked about that. So due to higher solubility and a faster diffusion of CO2 compared to O2. And that's why what happens is it needs lower ECMO flows for CO2 removal than O2 addition. Again, if you have only a hypercarbic respiratory failure, you're putting on ECMO, you don't need is a huge flows. That's what I'm talking. AV ECMO is enough there.